You all right? So I'm Kelly and I'm the clinical lead with Flen, and this is Kelly, and Kelly's in marketing in Flen. So between us, I'm going to go through looking at some of the challenges we face with regards to complex wound care. It's obviously a very whistle-stop tour because it's a quick programme. Kelly's going to do an interactive bingo game at the end. There's prizes in it involving chocolate. So it's hopefully a little bit of fun. So my background, I'm a tissue viability nerd by trade, and I still keep my hands in a vascular clinic, and I'm in the clinical role with Flen. But what I'd like to do today is really take a step back from the wound itself as well. So we probably have more challenging caseloads than we've ever had before, whether you're in a community or acute trust. I don't think it matters where we are, we're faced with more complexities. So if you could just go on to the next slide. We have regular foot clinics, we have pressure ulcers, we have moisture lesions, we have surgical wound sites, surgical wound dehiscence, loads of things we have to face on a daily basis. So what I want to do in this session is just to take a look at zooming out and zooming back in again on the wound so that we can get the optimal care for these patients. So obviously this is a leg ulcer. If we were just to look at the wound itself, if we have, whether we've got a home visit, whether we've got someone in the practice, whether it's someone in a nursing home, if we just looked at the wound, we could probably help that wound. We could probably know, need to clean the wound, need to keep it healthy. However, we're not going to get the optimum outcomes for that patient if that's all we do. So then we zoom out a little bit. So this wound, this is a lady called June that we're going to look at in more detail throughout this presentation. Not a real name, by the way. And we can see she's got a leg ulcer. So that's one element of zooming out. We know that primary treatment, standards of care for leg ulcers, if it's venous, is we need to get them into compression bandages. So we'd do all the assessments, we'd make sure we do the holistic side of the etiology. So the secret to any wound, whether it's a pressure ulcer, whether it's a foot ulcer, whether it's a surgical site, we need to know why it's there in the first place. And if you're managing a wound that we don't know why it's there, that needs to be our priority. We need to know why they've got that in the first place. If we know how they've got it, so for example, Vera may have knocked it on the stool when she was gardening, little wound that never healed. So we know why it's there, but then why is it not healing? So it's all these whys that we need to have in mind before we even look at challenging the wound bed itself. And that's just one zoom. The biggest thing we need to do first is this side of things. So whatever setting we're in, generally we know the patient's medical history before we even see them. We have access to their notes, we have access to their services, unless you're in an emergency care setting. We generally know June has COPD. We know the likelihood is she's probably not laying flat when she goes to bed. She's not going to be able to breathe so well. So the bane of my life when I was in the community was the rise and recliner chair. They'll all sleep in the rise and recliner chair because it helps them sit up. However, with a venous leg ulcer, this is actually a mixed leg ulcer, but with a leg ulcer, we need them to elevate the leg so we can get that venous return. We need to get to, so we kind of know, we can predict what we're facing before we go, and it's this side of things that is the one that will ultimately lead down to the wound so that we know what we're doing. Type 2 diabetes, we can check when they last had a diabetic check. We can check how their blood sugars are going. So all of this we can kind of predict and hopefully manage, and it's this, if we can get this right and then that right, the last thing is the wound that we need to do. Now the impact on the patient is something that they will tell you and how they're feeling, and that is a different topic, but the impact on the patient of the wound, if we can help them with this or tell them how we're helping with this, often it helps them to help themselves as well. And this is where the standards of care come in. So we've done all the assessment. We know that, she doesn't go to bed because she's struggling with her breathing and her mobility is not quite what it used to be. She's got osteoarthritis, but she's willing to try and just prop herself up with pillows, put her legs up. We've had lots of conversations about her underlying comorbidities. We did a Doppler assessment. We've assessed the leg ulcer. We know she needs compression therapy, and it's the compression that is going to heal the wound. And then if it's a pressure ulcer, if we relieve the pressure, we get rid of the cause of the problem, that will facilitate the healing of the wound. A foot ulcer, So I've worked in the tissue viability arena for 25 years, and I still wouldn't know how to offload somebody with a foot ulcer. So when do we need to refer? When do we need to get help with this underlying problem? Depends on what setting you're in, because I'm aware there's lots of different settings here. There are a plethora of best practice documents out there. So if you're in a setting whereby you have specialist services, they will often take these and give them to you in a pathway or a guidance. If you don't, and I know there's a lot of settings, for example, some practice settings, some nursing home settings, that you won't have this, make sure that you have a good look at these. The Wounds UK website, there's National Wound Care Strategy websites, there's best practice documents, there's Made Easy documents, all that guide you towards etiology specific treatments. So we've optimised the etiologies, we've diagnosed. If your patient's not diagnosed, that needs to be your priority so we can get the right treatments. And then we're going to look at the wound, and the wound is the thing that we probably do last. And I'm not going to go into the TIMES framework because it's been around as long as I have, but it is a really nice acronym to use and help us look at the wound bed itself. So we'll take a look at some of the things that we need to consider when we're doing the TIMES framework. So I know 20 odd years ago when I was looking after patients, you'd kind of let them give their wounds to you, wouldn't you? You'd kind of, I'm going to manage this wound and I'm going to help you heal. Now, the world's changing. If we can get the patient to help themselves, they need to. And if someone gives me ownership of something, I try harder. If someone else can do it for me, I'm all right with that. So it's making sure that we've got that element of self-care as much as possible. It's not possible everywhere. So, for example, I mean, I'm focusing on leg ulcers, but this can be transferable to anything. If you've got a patient that's fairly fit and mobile, are there leg ulcer treatments with compression therapy they can do themselves? Is there dressings that they can put on themselves, and we need to give it back to them wherever we can? Not all the time, but most of the time. Pain relief, get the GPs involved, get the pain teams involved, get all of the other service involved, because if we help them with the pain, then they're more likely to help themselves as well. Healthy tissue. So we'll take a look at June's wounds in a minute, but very, very rarely do we have a wound that's fully unhealthy tissue. We generally have a mixture of both. So what we'll do is we'll focus on debridement, but then we've also got healthy tissue in there as well. So it's just making sure that we choose a solution that's going to protect as well as do what we need to do to debride, if that's what we need to do. And odour. So there are very few wounds that don't smell at all. I mean, a grade 4 pressure ulcer, if anyone's seen them, you smell them as you walk in the room. But that's the devitalised tissue, and that's the very poorly patient that's alongside it. Odour, look at the causes. If it's a treatable cause, then let's treat it. So, for example, with a leg ulcer, often it's that there's so much exudate because you've got the excess fluid in your lower limb, but also you've got the microbes. So is it the microbes causing the odour, at which point you can do a topical antimicrobial that'll reduce the microbes? Is it the fluid? We'll get them in compression. Sometimes we can't get rid of all the odour, at which point I've seen there's some odour control dressings here. Use the things that are going to help them with the kind of combined treatments aims. And the idea is that we make these patients comfortable, because if I had a great big leg ulcer, which luckily I haven't had, it's the odour that would cause me the biggest problem. So we need to just try and manage all of this at once. But once again, it's the etiology side of things that we need to 100% get. And document absolutely everything. If there's anything, if you're kind of really pushed for time, and it's one thing that goes, don't let the documentation be the thing that you don't do. What you don't want is to be hauled across the coals and say you didn't do something, but you did, but you didn't write it down. So just always put why we've done what we're doing. So we're going to come back to the lovely June. You can see she's got a nice pair of shoes on there. She's unlikely to want compression if she's got these nice pair of shoes that she wants to put on. But this is our conversations. So she's 84. We know she's not a spring chicken, so her risks are probably higher of infection. She's had it for 6 months. She's probably put Sudocrem, TCP, toothpaste, whatever she's found in the cupboard on this. But if we take a look at the time framework, we've optimised that side. That's the thing we've prioritised. She's got moderate exudate. She's not going to bed, therefore the exudate is going to be high. It's not progressing. So the wound bed itself looks fairly nice. It's 80% granulation tissue. There's 20% slough, But if you look at the wound edges, this wound hasn't moved for a long time. There's no signs that this wound is healing. There's no edges coming in. There's no nice, if you can call a wound niceness of the wound that is progressing. So we know that this is stuck. So if we take a look at the debridement side of things, once again, always ask why. Why are we doing what we're doing? So we've diagnosed her, we've done the hard bit, we know what she needs. She needs compression. However, the wound bed itself, we need to clear it of this devitalised tissue. And the reasons why we have to do this is, the primary reason is that it's a breeding ground for infection. It's lovely, it's warm, it's moist. Bacteria absolutely love it. They'll have the babies there, they'll make families. They'll have a great big infection fest within this leg ulcer, which is why a lot of leg ulcers get the recurrent infections. It's just a nice environment for them. But also it's a physical barrier to healing. And so the cells are quite delicate little souls, and they don't want to fight against anything that's in there. So, which is why debridement is really important. It's become more pronounced over the last few years of the importance of debridement. And this is a great document. It only came out a few months ago. Just have a good read through it. It just describes the debridement processes. So Flaminal is the autolytic debridement, and most dressings around here work by autolytic debridement. So it's very uninvasive, it's at the top of this, and it basically provides an environment for our body to debride themselves, so it helps the body debride itself. However, if you've got a wound that you maybe suspect biofilm, or it's kind of quite a stubborn wound, you probably need to mix it with something a little bit more invasive. So you might need to use the debridement pads or the other things that you've got access to just to kickstart it and give that good debridement. But then you can help the nice, gentle autolytic debridement. And now we're going to move on to inflammation or infection. And I think arguably within wound care, this is the hardest one, because to define the two is quite difficult. GPs generally will always give antibiotics because it is hard to differentiate. However, with June, she had a large wet leg ulcer. We expect the wet because it's a leg ulcer, but she's just been on antibiotics. She's been on a course of antibiotics, the full course. She does have some erythema, but there's no signs of actual infection. She's got wound pain, but she had that before, so there's no distinct changes in her. However, she is at risk of infection. Now, the decision with June was made to apply something that's going to reduce that bioburden so that she's not going to again go on to get infected. And then the M. If we get the T and the I done really well and we have the underlying etiology sorted, the M will often balance itself out. So the moisture balance will often reduce, or the excess moisture will reduce. So we need to make sure she's got sufficient absorbency on there and the dressing frequency is enough. Now, with today's society and today's world, and we don't have enough time to do anything, this is the thing sometimes we have to fight against. When we first get a patient in a product or a dressing or a bandage system, the frequency needs to be high and then we drop it down so that we can measure what's happening. Now, if we do it low, then we end up with the subsequent effects of not dressing enough. So the investment at the beginning will give you time in the end. So what I am going to do is describe how Flaminal works with regards to the times framework. Has anyone not heard of Flaminal? Everyone always has. That's okay. So obviously this is very quick. Any more questions, the lovely people on the stand will be able to answer your questions. But Flaminal has 3 modes of action. So one, it's an autolytic debrider, and it's really powerful debrider. It's quite a nice debrider. It will lift all that slough and the debris. It has an antimicrobial enzyme system within the gel framework. So it's quite unique in that it's a gel, not a topical dressing. But within there, I'm going to show you what the enzymes do. The enzymes will kill anything that's absorbed within it. It donates no antimicrobial into the wound. It all happens within the dressing. So because of this, it's non-cytotoxic completely to the nice healthy tissue. And there's lots of evidence that shows that, especially like June's wound, where you've got quite a lot of nice tissue as well, it protects all of that and it won't delay the wound healing because it's just very gentle. And it has the absorbent alginate. So there's 2 types. And I'd say if you've got high exudate, use the yellow one, the Forte, and as the exudate drops down, swap to the lower one, or vice versa. It's a step up, step down approach. The enzymes. Now obviously we don't put wine and cheese and milk on someone's leg, but the enzymes, this is just to show where they're taken from. So we get the glucose oxidase from fungi. It's also used in things like wine. It's used in everyday products. Lactoperoxidase is taken from milk, and it's actually used in long life milk to help prolong the life. Guaiacol is just a small protein that we help to pull everything together. But it's in things like Parmesan cheese. So it's quite natural products that we're putting on the wounds, but it's quite powerful at killing the microbes that come in contact with it. So if we very briefly go back to the lovely June, and just to show how Flaminal worked on her. So I'm not going to stand here and tell you Flaminal healed this patient's wound because it was the compression and the nursing care that did it with the underlying comorbidities. But what Flaminal did is it helped support that. So when we put the product on June, we knew she had the excess exudate, we knew she had the excess debritalized tissue within there. She had the lovely healthy tissue that needed protecting, and that's exactly what Flaminal did. So after 5 weeks, you can see the wound is a really nice size, it's nice and clean. It stopped any infection. She didn't get any infections in this wound. It helped clean it nicely. And one of the big things is it helps with pain. So lots of the research we do, and especially in my role, the main feedback is it's really soothing. So it's nice for the patient's wounds. Carried on with the Flaminal Forte, which is the higher absorbency, because the exudate stayed quite high. She was almost healed at week 8, and you can see it's a really nice wound. And then she went on holiday. And so then, but at week 8, the Flaminal Hydro was used because the exudate had dropped right down. It was almost healed. She didn't need the Flaminal Forte on there. And hence why there's a further 10 weeks. But 18 weeks is quite a nice healing time for her. She'd learnt to get her quality of life back together, and she just had as nice an experience as you can with her leg ulcer. And this is just an example. Just make sure you step up, step down as needed with Flaminal. One's got more alginate than the other. So what you might find is if you're left with alginate deposits, you probably need to drop down to Flaminal Hydro. If you're changing the wound and maybe you're getting maceration, go up to Flaminal Forte. So just choose the one that's right for your patient. Often, if you go into the next slide, I'll show you how you can store it and keep it. But if you've got someone who has a long-term wound, having both at hand is quite a nice thing to do. And it can be used in almost every wound. There's very few it can't be used in. Don't put it near your eyes, and that's the only contraindication for it. But yeah, it's absolutely fabulous on leg ulcers. Also really good on hard to dress areas. So it's used perineally, it's used on feet. Because it's a gel, it conforms nicely and it'll go into different spaces. And this is Heinz 57 varieties of how you can use it. But bear in mind, once open, a Flaminal tube can stay open for 12 months. So it's got a long shelf life once it opened. Put a bit of Mepore, Micropore on it and tell it when you've opened it. And then if the patient just keeps them, if they've got recurrent ulcers, you can use it again. One of the best ways for leg ulcers, which is in the little bingo game, is just to put it straight onto the dressing. So whatever secondary dressing, whether you're using a silicone dressing or a foam, doesn't matter, just squirt it on there. You don't have to be perfect, it just has to be thick. You just have to make sure it's 5 millimeters thick. You could use it with a nozzle. So if you've never had nozzles, ask the guys to bring you some, because they're free. We can't sell them, so we give you them for free. It looks a bit like an Anusol nozzle, if anyone's seen them. And they're really good to help put in cavities and help dispatch it. But the nozzles are single use, so don't keep them on the tube. And then syringe is a brilliant way of doing it. So I've done this with a guy with a pilonidal sinus. So you take the top off the syringe, decant it in and put the top back. You can measure how much you're putting in. So you can see the wound bed coming up. And there was a guy I was treating who had a wound of 5 millimeters, and he came back, he said, I only got 3 in that time, so it's getting smaller. So you can have those conversations. And then you can use spatulas, you can do it direct from the tube. There's lots of different ways you can do it. Whatever works for you, you go for it. So I'm going to hand over to the lovely Kelly, who's going to do a little bit of a bingo game. So if you need any pens, get them out of your bags, or we've got some spare ones.
Can everyone hear me all right? Good. So all I'm going to talk you through is a little bit of a bingo game that's related to some real world case studies that Flaminal's been used on. So taking a lot of what Kelly talked about into practice and just kind of testing your knowledge a little bit. So I'm going to read out a little bit of a background on a case study and ask you 3 questions. Basically, what were the treatment objectives? What formulation of Flaminal was used? And what application method of Flaminal was used? So each one of the correct answers will correlate to one of these icons here. So for instance, the treatment objectives, you've got options of debriding, managing exudate, antimicrobial protection, protecting granulation tissue, reducing pain, reducing odour, protecting the surrounding skin, and protecting exposed bone and tendon. It's not an exhaustive list, but this is kind of what we got to choose from. Question 2, in terms of what formulation of Flaminal was used, you can use either hydro, forte, or both. And then in terms of what application method was used, as Kelly's just been through, you can do it directly onto a secondary dressing, using a nozzle, a syringe, directly from the tube, or a spatula. Make sense? So I'll read out a little summary now. With the answers, just shout them out and we'll kind of have a discussion. And then if you've got that correct icon on your sheet, cross it off. And then whoever's closest to a line, shout out that you've got a line. And there's chocolates at stake at the end. Okay, so next slide, please. So this is a leg ulcer from a 50-year-old male patient. He has a high BMI, hypertension, circulatory issues, and he's on a concoction of medication. He developed this leg ulcer secondary to a minor injury, actually on his lower right leg. It measured 6.5 centimetres by 5 centimetres, and it had a 1 centimetre depth. So you can see here a little bit of depth, but you can see it's pretty much 100% devitalised tissue, a mixture of necrotic tissue, fibrinous slough, and it's got very high levels of exudate. There was a positive swab for anaerobic bacteria, Proteus and coliform, and because of the high levels of exudate, the edges of the wound were very macerated. So that's a little bit of a background on it. In terms of the top 3 primary objectives that the clinician thought of when treating this patient, what do you think they could be? Just shout them out. Pardon? Debriding, yes, definitely. So debriding that devitalised tissue was one of the top treatment objectives. So if you've got this debride icon with the little arrows, cross it off. What about a second treatment objective? Pardon? That is definitely something that is a treatment objective. It wasn't in the top 3 that was kind of listed when she wrote this up, but yes, it makes sense. With the high levels of exudate, protecting that surrounding skin would be key. So you're not wrong, but it's just not one of the top ones. But yeah, great answer, thank you. Oh, sorry. Antimicrobial protection, yes, definitely. So because there was a positive swab for anaerobic bacteria, one of the main treatment objectives would be to reduce that bioburden and protect from infection. So if anybody's got this antimicrobial protection icon, cross it off. Third and final one. Oh, who was that? Yes, managing exudate, correct. So with those high exudate levels, you are going to need to manage those, and that leads to the lady over here that said the protecting the surrounding skin. So by managing that, you are going to protect that surrounding skin. So if anybody's got managing exudate with the little droplets, cross it off. Okay, so second question. Bearing in mind that the exudate levels were high to start with, but they did decrease over time during the treatment, what formulation of Flaminal do you think was used? Forte, yeah. Any advances on Forte? Both, yes. So you're both correct. We started with the Forte because at the start, those exudate levels were high, so we needed that extra absorption, so definitely correct. But as the lady said over here, throughout that treatment, the exudate levels actually decreased. So they started to see those white flakes and they could step down to Flaminal Hydro. So if you've got the icon here that's like little blobs, cross it off. Third and final question. What application method was used for Flaminal? Onto a secondary dressing? Yes, correct. So the clinician would have squirted the Flaminal onto the secondary dressing and then popped that directly onto the wound. So if you've got the icon here that looks like a little bit of a plaster, cross it off. Do we have any winners? Anybody got a line? The antimicrobial one is just, it looks like a little bug here. I don't know whether you can, I can't move the screen. It's got like a little bug on it and a little shield next to it. Have you got a line? Well done. You got a line as well? Brilliant. Oh, we've got a few winners. So thank you very much. That's everything from us today. If you have any questions, myself and Kelly are here all day, or there's also the guys at the stand. So thank you so much.
Thank you.
Thanks.